It's 2 minutes past the hour, and it looks like our participants coming in are plateauing. So we'll get started. Welcome, everyone, to Pilon during collections. Help me make the right choices, because doing a complex Pilon during your collection period is going to be a super happy thing for everybody. We would want all of you to be very prepared, and we wanted to share some of our experiences and wisdom, and hopefully you can do the same with us as well through both your questions and comments as you have them. I am your moderator, and we have two great speakers today. We have Dr. Clay Spittler, who's Associate Professor and the Trauma Fellowship Director at University of Alabama, Birmingham, Alabama. And we have Dr. Carol Lin, who is from sunny California, Cedars-Sinai Medical Center. And these two faculty have a plethora of experience that they will be sharing with you today, both interactively through questions and also through just sharing of a lot of their wisdom and information. A few statements to make about AO North America, independent not-for-profit surgical society dedicated to improving the care of our patients with musculoskeletal injuries. We do not endorse nor do we promote the use of any specific product or service associated with commercial entities. And the equipment that you may identify in this course is really for demonstration and teaching purposes only. And the intent is to enhance your learning experience, not to promote any particular product. As you contemplate the talk that you're going to be and the interaction you're going to have today, I want you to look at this very telling image. I remember reading this paper and thinking, oh, Lordy, what am I getting myself into? All these different fracture lines that constitute the patterns that you could see in a pilon or a plafond injury. So quite an array. One of the things that we hope is by thinking about this, by discussing it, by interacting with those that have other shared experiences, and perhaps different experiences than you, is that this will start looking a little more like this. And that was actually one of the points of the paper. It's a paper by Bandari that you should all look at. And really, if you take those patterns, but you start collecting those patterns together, you actually find that the vast majority have similarities. And so we hope that you'll be able to recognize some of these patterns, whether it's to stage or not to stage, whether it's the approach to use, whether it's the particular way in which you're going to create your reduction and a great looking x-ray and a great outcome for the patient. A few things on Zoom as you contemplate all those fracture lines and think about all the great things you're going to learn today. All microphones have been muted and the video cameras turned off, so we cannot hear you, nor can we see you if you happen to be in your pajamas. Please send all your questions and technical issues through the Q&A box. So not through the chat, but through the Q&A box. And as our speakers are sharing their wisdom with you, I will be monitoring this Q&A box. Some of those questions I will answer and put into the answered column. Some of those we will engage our speakers and we'll address as a group. And the chat box, like I said, is for faculty and staff. So please use the Q&A box so that I can see them and we can address all your questions. So as a broad overview, we want you to join our interactive and experienced faculty for a case-based answer-focused discussion on staging considerations, surgical approaches, reduction tactics, fixation techniques, and hopefully avoiding complications for the treatment of pilon fractures. This is our overall outline to give you a sense of where we're going to go, staging, some questions discussion, although that may be very broadly interspersed throughout our presentations. So many approaches, how do I choose, systematic reduction strategy, when to deviate, as well as along the way, we'll discuss some pitfall sabotage and complications. And we can also address those separately at the end if there is time. We'll have a brief wrap up, and we'll all be on our way to enjoy the rest of our evening. And with that, I will turn the screen over to Dr. Lin.
Thank you very much, Dr. Ahn. So we're going to go very quickly through these first couple of topics, which is to stage or not to stage, and then how to stage. I think most of us have had some experience here, and as we all know, we can go to the next slide. The key issue here is the soft tissues. For plafons, you really have to respect the condition of the soft tissues, even if you have a simple fracture pattern, and they are paramount. And when in doubt, especially if you're going to be doing this during your board collection or in general, it never hurts to stage it in some way, shape, or fashion. And we all know that an external fixator is great for when you've got a length unstable injury, or if you've got an injury that cannot stay reduced in a splint. There's nothing wrong with maintaining a reduction of a plafond while you're waiting for the soft tissues in a splint. It's just that many of these plafond or pilon type injuries have a length unstable component, and so splints don't always work. So we're going to go very briefly through the classical indications and some controversial cases for this area. So let's go to the next slide. So this is a very obvious example of when you should X-fix. You've got a terrible bone injury. You can see how shortened it is, how comminuted it is. The anterior half of the joint is really not very is not visible there, and even though the skin itself doesn't look too bad, you have a small open wound. So this is now someone that is almost in limb salvage territory. These open plafons have a depressingly high amputation rate because the quality of the soft tissues is pretty fragile. Soft tissue reconstruction is complex and dependent upon pretty robust tissues, which not every patient has. So this is a pretty clear indication for external fixation. Number one, reassessing the soft tissues and stabilizing them, and then bringing the bone out to length and stabilizing the joint so you can even get a CT scan to understand what the fracture pattern is for future planning. Next slide. And so this is another one, much simpler fracture pattern. You could almost say this is, quote, just an ankle fracture, but you've got this massive blister anteriorly. It's a hemorrhagic blister, which indicates some deeper soft tissue injury. You've also got these serous blisters both medially and laterally. So this patient is not being well served in the splint, not reduced. And even though the fracture pattern itself is relatively simple, staging this and putting an X-fix on to let the soft tissues cool down is the appropriate thing to do. And then just very briefly, I'm going to ask JMO, Dr. Ahn, and Dr. Spittler, how do you guys handle these blisters when you're putting the X-fix on?
Personally, I usually unroof, and the hemorrhagic blisters I'll treat with Silvadene until they begin to look like they're reepithelializing, usually hopefully within 5 to 7 days, hopefully, but sometimes a little bit longer.
For me, at the time of the X-fix, I generally let them do what they're going to do. So if just gentle handling ruptures them, then I'll use the skin as a biologic dressing. I won't try on purpose to save them. So if they go, I try to use a biologic dressing. But I typically don't really unroof them until it gets close to the time where I'm thinking I might want to fix, and I want to see what's underneath.
Yeah, there's always a variety of answers. I tend to be more in the unroofing if I'm in the operating room already. If they're already leaking when I see the patient, then yes, I'll just finish it and drain it because I don't want to have this bacteria soup sitting there. But if they're intact and relatively robust and they haven't ruptured already, and I'm not doing this in the operating room, then I tend to leave them. So I kind of half and half depending on the context. And that's when I think one thing you're going to recognize for the plafond type injuries that it's all about context. Next slide. All right, so here's a good example. So this in the skin actually doesn't look too bad, but those little dots were not there when the patient was in the emergency room. So over the space of 4 hours, these tiny little blisters have shown up. And that is another indication for external fixation there, because this is just the beginning. It's going to get a lot worse before it gets better. And so just to remind people that the soft tissue injury at the presentation, it's not a static thing, it's an evolution. And so if something is changing that rapidly in the space of the 2 to 3 hours it took to get to the operating room, then that's a sign that you really shouldn't be fixing or putting anything definitive there, even if it's a relatively simple pattern or a partial articular pattern. That is something to keep an eye out for. And if you have that evidence of massive soft tissue injury, then you need to put an X-fix on and wait and stage. So that's another indication. Next slide. And here, okay, so here's a little bit of a controversy. So this is a patient who had a fall outside, showed up 3 days later, and looking like this. Okay, they'd been splinted at an outside hospital, and then we took the splint off, and you've got this, or you've got, what you've got here is a blister bed that's starting to epithelialize. You've got a lot of ecchymoses here. So pretty swollen still, but not egregiously injured in the same way that we had the prior example. So Dr. On, I don't know if they can do this, but I would like to poll the audience if they could and use their, put an answer in is this patient ready for the operating room? Would you take this patient? And we'll go to the next slide and I'll show you the X-ray real quick. So that's the X-ray, classic. In trauma world, this is sort of a simple plafond. You've only got the single fracture lines, big articular pieces, displaced, unstable. So this is your fracture pattern. And then you go back and take a look at the skin again. So a poll of the audience, who would fix and who would stage? So can you go back one slide to show a picture of the skin there?
Practically, the easiest way would be for you to put your comments into Q&A, and then we can take a look.
Yeah. So we'll give people a minute to respond. So you just put fix or stage. And we'll see who gets voted off the island. Stage, X-fix, stage. Yeah.
Everyone is afraid of that pattern. Everyone is
Yeah.
staging so far.
First one stage, second one operation. Yeah. Still coming in. Everybody stage. What would you guys do? There's no right or wrong answer, I think, in this situation. There's the safest answer. Dr. On and Dr. Spittler, what would you guys consider?
It's hard to tell. Is this the lateral side of the ankle or the medial side?
That is the medial side. The lateral side looked very similar, but there were no blister beds. So it just had that, it still had that Langer's lines pattern.
I'm going to go with my old colleague here, Michael Tallarico. I think I would stage this mainly out of fear. Even though I don't see fracture blisters, there's enough strange pattern of ecchymoses that I think there's underlying soft tissue injury that I'm not quite grasping just by looking at the skin.
Okay.
I think that's always certainly the safest thing to do. And I think especially early in practice, if you're unsure, then no one will ever fault you for staging this. So I think that, being conservative is the safest thing. And it may be that, this is 3 days out and this shows up in your ER transferred in or your clinic, and you're not really sure, and you stage them. And after 2 days in the hospital, they're ready. And I don't think anything is lost by only having had to wait 2 days for this. But I think, depending upon I think the lateral soft tissue looks like I might be willing to go after this acutely.
Yeah, so it's very, again, contextual. I think what we are seeing from the audience, and I think from our own faculty here, the lesson is, again, first do no harm. I think we get a sense from a lot of people that it's so close. It's really close to being there. You can see Langer's lines, which to me is an indication that the skin can tolerate some some expansion, like a little accordion. Those blister beds are starting to epithelialize. I certainly don't think you should leave it this way, because if you go to the x-ray, the joint is not reduced, right? If you go to the next slide, and just to review the x-ray, the joint is a bit subluxated posteriorly, which is not a good thing for the soft tissues either. So I wouldn't leave this in the splint. I actually ended up fixing this person because it was a posterolateral primarily approach for this most of the work here, with a small accessory medial window, and there were that patient ended up doing fine. But there were some social issues that were surrounding the patient where she couldn't really be in the hospital for a long period of time. And but I will say that the safest, and I think the most prudent thing to do, as you guys have all correctly pointed out, is waiting a couple of extra days, putting an X-Fix on, having a better understanding of what's going on, is the safest thing to do for the patient. I think as you get more experience and you start doing a lot more of these, then you can kind of get a sense and maybe be a bit more aggressive on occasion. But in truth, you should really, again, even if it's waiting for a couple of days, I think that benefits the patient. Let's go to the next one. Here's another controversial one. Okay, so here's one. Okay, this patient obviously was staged, but again, it has to do with a little bit of how do you know when to operate on the patient? Okay, so is this patient ready for surgery? If you've got these x-rays, okay, these are the injury x-rays, and then the skin looks like this. So no blisters, not that ecchymotic, but a bit poofy. All right, so we'll try the Q&A again. So fix now or keep waiting. Okay, how long? Okay, so Dr. On, we've got some questions here and some comments. Do you want to address them now or wait for the Q&A after? Okay, so some people we have fix. If too swollen, we'll wait. Fix, how long already would wait though? Stage, okay. So this one's a little more controversial, right? It's poofy, got more people who want to fix. Maybe it's because I said I fixed the earlier one, and so people are feeling a lot more bold. So we'll say that's been a week in the hospital. This patient has been a week in the hospital. Fix, Dr. Erdman would fix. Dr. Young says if there are wrinkles, okay, a lot of people saying wait until wrinkles sign. Okay. All right, so let's go to the next slide. So if that's the fracture pattern, what if this were the fracture pattern? What would you guys do? And the skin looked the same. How would you address this? Would you fix it right away or keep waiting? All right, so we've got a different fracture pattern. A lot of people want to wait for wrinkles. Okay, again, so more people wanting to fix this. Some people keep waiting. Wait a few more days, wait a few more days, wait a few more days, wait for wrinkles. So I think, again, this is all about context. So the patient is a little bit swollen. We'll say the patient is healthy, non-smoker, and you've got a simple fracture pattern versus you've got a complex fracture pattern. And to me, that makes a huge difference. Again, how much assault will you put on the patient versus how much swelling there already is? So I think the lesson here is it's okay to keep waiting. So Dr. Spittler and Dr. On, how long do you think you can wait for? So that was a question that came up. So say this has already been a week. What's the longest that you've ever waited for skin to be ready?
I think I've waited between 5 and 6 weeks once or twice in about 10 years.
Yeah.
Yeah, I would
What's
say
your
it's
average, do
pretty.
you think?
I've become more aggressive, and I'm probably closer to between a week and 10 days, and sometimes earlier. Depends on sort of the logistics of, is the patient going to discharge and come back to clinic, or are they an inpatient for the whole time?
Mm-hmm. Mm-hmm.
I think it's been pretty similar for me. Somewhere between a month to month and a half has probably been the longest. And just logistically, typically, because I'm most often on call on Monday, Tuesday time period, they'll come and see me the next week and then probably get scheduled for surgery the week after. So it ends up being about 2 weeks. And like you, I've gotten a little more aggressive. So I'm less likely to wait 3 weeks plus, more likely to try to get them done within 2 weeks if I can.
Yeah, and I would say that my pattern has been the same. I think when I first started, I waited at least a week for pretty much everybody, and up to 3 to 4 for a large portion. Now it's very much dependent upon how many incisions do I think I need to make, how many different approaches, how long I think I can the surgery is going to be. I think I've become a bit faster with these and a bit more efficient. So my soft tissue trauma from surgery is a little bit less than it used to be, and so that has also helped shorten the time. But I think when you're starting out, it absolutely is the best idea, and the appropriate thing is to wait until you see wrinkles, like real wrinkles in the area that you're going to be operating in. It's okay to wait up to a month, 5 weeks. Which most of the time you don't have to, but if you do, it's better to have a stiff ankle and maybe some post-traumatic arthritis than a wound that doesn't heal, free flap, maybe even an amputation, because that does happen with these, and it's not an unrealistic thing. So again, the context is really important. If the skin is mobile, if you've got Langer's lines, which again are the normal skin markings that you have, and it's a simple fracture pattern, then I think you can go. But if there's any concern, any doubt, then it's better to stage it and wait. All right. So then any comments or questions on that? Stage,
We do
wait for
have
wrinkles 2 to 3 weeks.
yeah, we do have a couple comments. One is Quigley traction for 3 to 5 days. And another, we will defer a little bit to the later sections as we discuss how we stage, what you might fix when, and the fixation strategy. So Michael Tallarico brought that up, and Joseph Avadia brought up the Quigley traction. Great comments, and I think the fixation strategy will be further addressed.
Okay, great. So let's jump into the next PowerPoint, which is how to stage, which is really important, especially as you become the tertiary or quaternary provider for these patients who sometimes get ex-fixed out at non-trauma centers or non-trauma trained people. There are a lot of ways you can to do a staged fixation incorrectly. So you have to learn how to manage those things, but hopefully avoid them in the first place. So if we can go to the first stage matters. All right, so go pretty quickly through this. So what are the goals of the first stage? Just a basic review: restore length, rotation of alignment. If it's open, you want to debride anything contaminated or dead, stabilize the soft tissues, and try to set yourself up for future success. Be cognizant of what incisions you've made, and really, number one, really try to restore that length. If anything, you want a little extra length if you can. Next. So here we go. This is a nice example of external fixation. So the pins are out of the zone of injury. So, you can imagine where your plate's going to go, at least a couple zones of comminution above, at least 1 to 2. There's no pin site there. There's a little bit of distraction at the joint, and you've kept the talus under the tibia. All right, so those are the key principles here, and you'd be surprised at how challenging that can be and how often it is not followed, especially joint distraction. If you can get 1 or 2 millimeters, it really makes your case easier down the road. You can see here we got the joint distracted, the posterior cortex there is out to length, and the fibula is out to length. So these X-fixes are just as technical as anything else. It's not like you can, quote, slap one on and then ship them out. So next slide. So again, if you've got a CT that's not aligned, that's comminuted, it doesn't provide as much information as one that is out to length and distracted. Next. So here you have an example of one that's totally displaced. They got the CT before the patient was in an X-fix, and it's really hard to interpret what's really going on. And then now you've got another CT scan that you have to get. Next. Okay, so what to do with the fibula? So I think being able to stabilize the fibula in a way that does not affect your future fixation is really, really helpful. And there are a couple of things that you can do to sort of maximize your efficiency with this. So one of them depends on the fracture pattern. So here you've got a really, really shortened tibial plafond. It's a type C injury. And you've got a transverse fibula fracture, and so that lends itself to different types of fixations well. And then if you find that you need to do an open approach, then I'm going to go very briefly in how to make that approach without creating more problems for yourself later. All right, next. So here's an example of a patient that I saw in clinic. She had been fixed at an outside hospital from a plafond injury while skiing. So she at the ski resort, she went to a busy sports surgeon, very experienced sports surgeon, who stabilized her with an external fixator and then fixed the fibula, which was a very common thought about 20 years ago, because if you fix the fibula, then you help stabilize the fracture and you bring it out to length. But there are really a couple of really concerning signs here. So number one, it's not reduced. So you can see here the fibula is flexed, and so she's still short. The incision is direct lateral over the fibula, which now creates some challenges in the definitive fixation. And then if you look, the external fixator pin for the calcaneus is right in the middle of the body of the talus, which is actually a little close to some pretty important neurovascular structures. And in fact, when we took this X-fix off, she had some pulsatile bleeding from her medial calcaneal pin site, which was alarming to say the least. Luckily, I think it was just a branch of the posterior tibial artery and not the whole thing. All right, so this causes some problems. So these are things that you don't want to do, okay? It is okay to open and fix the fibula if you think it's necessary, but you have to be very thoughtful about it. And in fact, I would suggest that if you're not going to be the definitive person to take care of this wound, if there's a way to avoid that, then that's better. Try to avoid making any incisions other than maybe the stab incision or something within less than a centimeter, so that you're not compromising future fixation plans. Next. So here's another patient who was the victim of a ATV rollover. And again, they followed that same principle of let's fix the fibula. And you can see here what has happened to that lateral skin. And in fact, her skin was so compromised that she stayed in this frame for 6 weeks, and that was her definitive fixation, and then came back for bone grafting later on. So again, be thoughtful about your incisions. Next. So if you're going to fix the fibula and it needs an open approach, then think about an approach that maximizes your access and options for later fixation. And so a more posterolateral approach is generally recommended, because you can use that for a posterolateral approach to the plafond. You can use that to fix the fibula, and then you still have some room for an anterolateral approach and an anteromedial approach if needed in the front. Next. Alternatively, if you have a transverse fibula fracture, then you can use intramedullary fixation of the fibula, which is really helpful. So that's just a percutaneous incision distal to the tip of the fibula, generally out of the way of any incision that you're going to make for the plafond definitive fixation. And then you can put a wire, a TENS nail or a flexible titanium nail up the canal, and that will hold the length of that lateral column very well, especially if you've got a transverse pattern like this. And so occasionally I will make a small accessory incision, like 1 centimeter over the fracture, to help manipulate it to get it reduced, because I think that's small enough that the soft tissues can handle it. But in general, I try not to make any substantive incisions over and around the ankle if I don't need to. All right, the next slide, please. So when in doubt, leave it alone. Don't box yourself out, and get the X-Fix on, and then wait. All right, next slide. So a couple of things. We talk a lot about skin bridges, leaving room for skin incisions. And in general, you want your skin bridge to maintain a length to width ratio of about 1.5 to 1, certainly less than 2 to 1. So it's less about the actual number of centimeters, because it used to be 7 centimeters, and then some studies say 4 centimeters, but it's more about how long the train tracks are. So if you, and this is based off the plastic surgery rotation, skin rotation flap literature, where you can, you know, these guys are the best at moving pieces of skin around. So they've really defined how small a piece of skin you can move without compromising the blood flow and needing it to be truly pedicled. So if you can keep your length to width ratio of about 1 to 5 to 1, certainly less than 2 to 1, then that's generally a safe approach. And that's why these small percutaneous accessory incisions are well tolerated, even if you have a lot of them around the body, because they're so short that you can really tolerate more of them. So you could have your anterolateral and a medial approach and a little accessory right in the middle. And even though it's right in the middle and technically it's measuring maybe 3 centimeters from each end, it's only a stab incision or a little poke hole. And so the skin can generally tolerate that. Okay, so next slide. So you can see how a direct lateral incision really makes it hard, like a long direct lateral really makes it hard for you to get that anterolateral or posterolateral incision. And that's why generally if you have to fix the fibula, don't do a direct lateral, move it more posteriorly. All right, next slide. So there you go. So if you move it more over the peroneals, then you can use that for your posterolateral approach, and then you have a lot more room for your anterolateral approach. Okay. So take-home messages, just really try to avoid any large incisions. If you have to fix the fibula for whatever reason, because it's just that grossly unstable and an X-Fix isn't even holding it, then really think about where your incision is going to be. And ideally, it should be you should be the person to be doing the definitive fixation. All right. So
while we're transitioning, I do want to bring up one question that I think we can address, which is, do you use VT prophylaxis during that staging time?
Yes, I do. I tend to do Lovenox because it's got a short half-life of 1 day. And if something changes with the patient, then we're having to wait 2 or 3 extra days for it to come out, for the half-life to stop. I do not do antiplatelets for that reason too.
We have a scoring system. So if you're 20 years old and you don't smoke and you have an isolated Pilon fracture, then I typically do not. But if you're 50 and you smoke and you have more than one other comorbidity or any other fractures at all, then you're going to get Lovenox. Is the quick and dirty on that.
Yeah. We use sort of an in-between risk-based system.
Many of these patients are in the hospital most of the time. It's actually, for us, it's uncommon that the patients can go home in the bit between. The vast majority are in the hospital, so they're getting some sort of injectable prophylaxis. All right, so we'll move quickly to how do you decide your approaches and some of the meat of this. Okay, so how do you decide what approach to use and what construct to use? And I'm going to kind of go through things pretty quickly, sort of my approach of, how do I go through all these different options? And then with Dr. Spittler, we're going to have a few more, sort of more in-depth case-based approach. So approach to these fractures. So you've staged it, you've spanned that, the skin is looking great, and you've got that 2 to 3 week period of just obsessing over what to do, and use that time. You want to know the fracture, you want to love it, you know every piece of it in your mind, and that's a critical thing of really studying it. And I go over these CT scans, and the 3D reconstructions have been very helpful. I go over them over and over again, and you really come up with a sequence. And so the way I approach these is, number one, as long as the skin itself is going to dictate, but we're going to presume that the skin does not have pre-existing incisions that you're obligated to use. So in these situations, I think, okay, what does the fracture need? And where do I need to support it? So I need to put a plate to resist the initial fracture displacement. Most of these have displacement in some direction, so you want to push against that. But then you also want to resist displacement from physiologic loading. So as the patient weight bears, they tend to like to fall into varus. And so many of these plafons, even if they were not initially displaced medially, still require some medial support, because as they begin to weight bear, the load tends to push it into varus. And so you either have to make sure that the bone itself is competent to support that, like it's got a nice transverse, well opposed fracture plane, or you need to support that with a plate. And so once I decide that, this is the construct that I think I needs to have in the end, then I think, okay, I also need to know what approaches will allow me to see what I need to see. Do I need to book open that Chaput fragment to access a dye punch, or do I need to really get an anatomic reduction of that posterior malleolus fragment? So which one of those do I need to see? And then what approaches will facilitate hardware placement? And so you may have you can make small incisions to get hardware up, but you may not be able to get the screws in or the screw trajectory that you want. And so I kind of go through multiple iterations of this path over and over again until I come up with a combination of approaches and hardware that meets all of those things that I think the fracture will need. So that's why you really, really need to have a good CT scan so you can really understand what the fracture pattern is. Okay, so let's go to the next slide. Okay, so for example, here is a healthy 55-year-old man. He fell 8 feet off a ladder. Okay, this is a closed injury. So a couple of things here. He's shortened, but the fibula here is transverse, or it's maybe, it's minimally shortened, but very comminuted metadiaphyseal component. There is definitely anterior translation, subluxation of the joint. I don't really understand what the joint is doing right now, but I can see there's a very large posterior malleolus piece. There's a large medial malleolus piece, and then there seems to be a lot of tragedy happening anteriorly. Okay, so we're going to go to the next slide, but the fibula seems okay. So now we've got him in an X-fix, okay, which has pulled things out somewhat. There's this transverse fibula. Again, you've got what we suspected, which was a large sort of medial piece, but the cortices there are comminuted. You've got a displaced Chaput fragment up there, and then you've got this relatively large posterior intact cortical piece that gives us our length read. All right, so we'll go to the CT scan. Okay, here's our CT scan as we come down. So you've got at the top here what looks like an apex there of that posterior cortical piece. Then some terrible things happening there in the metadiaphysis. And then as you come down, you've got kind of that classic Mercedes-Benz pattern. And then a dye punch. Okay, so I know that I need to open up the front to look at that dye punch. I need to somehow make sure that I've got some anterior support and most likely medial support. And then I need to somehow make sure I grab that posterior cortex. Okay, so we're going to go to the next slide. We'll go pretty quickly. So as we go through here, you see the anterior portion. So the medial side has a little bit of a read, the anteromedial side. You have the direct medial here where, again, you've got a little bit of a read with this intercalary segment. And then posteriorly, you've got this very short apex here. So I have to decide, is it worth it to go after this apex when it's such a short read and it's going to be very hard to stabilize this? Or can I allow it to be out to length where it is and then not really count on that to be anatomic? And so when I go to the next slide, and so, you know, again, goals are get the talus under the tibia, support the columns appropriately, get anatomic reduction of the joint. Go ahead, next. We went over the approaches. Again, keep that skin bridge approach. There are all these different approaches that you can use, and go to the next. And so this was my list of things that I was thinking about, okay? And the columns, anterolateral comminution, anterior displacement, anteromedial face has some read that I can put together to get my length and alignment. Posterior malleus is simple with an apex, but it's a very short apex and it's out to length in the X-fix, and it's a simple fibula out to length. The joint has a large medial and posterior mal, there's a chaput and a die punch. Okay, next. And this is my plan, okay? I want bridging fixation for the metaphyseal comminution. I want anterolateral support, and I'm going to use that anteromedial read to reestablish length. I want to support the fibula as well, and I want to support the medial side. So my plan for the joint, I'm going to open the chaput to access the die punch, so I need some sort of anterior fixation. I'm going to use the posterior malleolus and the talus as a reduction aid, because that posterior malleolus read there is going to tell me if my posterior mal and my medial mal are meeting up together appropriately. I'm going to reestablish that relationship and then get some interfragmentary compression. So if you guys keep going. And then keep the X-fix on, support the lateral column by doing that fibular rod. Do an anterolateral approach, use those anteromedial cortical fragments to bring the medial mal to the intact diaphysis, and then look in the back between the posterior malleolus and the medial malleolus to get the posterior malleolus anatomic, because I know it's out to length already in the X-fix. Book open the chaput, bring the die punch down, and then close the chaput and compress across the joint. All right, so that's the sequence of events there. So I've got a posterior medial clamp, okay, with that medial approach, which is still a nice broad skin bridge compared to the anterolateral. I've got that chaput fragment booked open, and then this is after the fibular wire. And then as I bring the die punch down to the top of the talus, I'm looking all around to making sure that everything is maintaining its alignment in the back and medially and anterolaterally. And then I'm bringing down and closing the book. And then what you can do when you're doing this, you can send the wires all the way from front to back like you would for a plateau, so that you can keep that reduction and just close the book down without having to remove those wires. And then I compress with the plate, through the plate using lag screws. And then I put my one screw up at the top so I can correct any anterior posterior. You can see there in the bottom row that there's still a bit of an apex anterior. And so I fixed it proximally with just the screw, and then I can pivot around that and then send more screws across to get that alignment back when that's the last thing to do. All right, next. And so this is what we had at the end. And then you can see all of that unstable comminuted medial column. And so we did, through that medial incision, a sort of MIPO type plating to slide that medial plate up. Next. And so that's what we started with. That's what we ended with an anterolateral and then sort of an accessory medial approach. Keep going. And then cast at 1 week, range of motion when the sutures were removed, and that was for the soft tissue rest, and then started progressive weight bearing in a boot at 8 weeks. And then next, there he is. That's him at 7 months. So that's just a brief run through of how you can go through your strategizing and how you select your approaches. I think we're going to move to Dr. Spittler now so that he can go over some cases in particular and then also some pitfalls to avoid.
All right, sorry, let me get started here. So my overall goal is to allow you sort of a process to go through to think about fractures, because they are all very different. And sort of the reduction strategies involve both the approaches and the actual reduction maneuvers, as well as the fixation constructs. And I think that it's hard to talk about one without talking about all of them. And we'll fly through a lot of this. I think at times understanding, the fracture is obviously critically important. And there are things you can do in the first stage that will help you with the second stage. So one of those would be fibular fixation. One would be making a C-type injury a B-type injury. Sometimes it's appropriate to fix the posterolateral fragment early. And other times you can use the open wounds that may be challenging to access that particular area that looks to be critically important towards the reconstruction through or underneath a smoky open fracture wound. So understanding the fibula first is critically important, right? I think if you fix the fibula wrong or incorrectly, you can really hose yourself because that sets in space the posterolateral fragments and the anterolateral fragments via their syndesmotic attachments. And so if you're going to fix it at stage one, it has to be anatomic. And if you're going to fix it first as a part of stage two, it has to be anatomic. I think that if you are uncertain if you can fix the fibula anatomically, then it should be the last part of your fixation, unless you're really struggling to maintain the alignment and you can do something that's more temporary, like an intramedullary device, can help sort of control the coronal and sagittal plane. It's better in simple fracture patterns, transverse or short oblique. But even in a comminuted fracture pattern, it can help control the coronal and sagittal alignment without significantly affecting available approaches later on. So again, if you can't make it anatomic, wait. So when do I fix the fibula first? I think if there's a lateral open fracture wound, so usually that's a varus failure, medial comminution, and a tension failure of the skin laterally, largely because I usually don't want to reopen that wound because it's transverse over the fibula. I will try to fix it at stage one. If the fracture pattern is very simple and I understand the whole thing, then I'll fix the fibula. But most often, I'm waiting these days. So here's an example of something you can do when you have significant diaphyseal extension. This can be a really challenging thing to control in the external fixator. You get the talus back under this posterior plafond, but then you have significant posterior translation through the diaphyseal component of the injury. And in these simple fracture patterns, traction in a very small open approach. And again, if you're not going to be the one to fix this definitively, don't do this. But I think that if you are that person, you can really set yourself up quite nicely through relatively small incisions. And that's what that looks like with two percutaneously inserted lag screws. And it allows you to center the plafond, or excuse me, the talus under the plafond a lot more easily. And now you have essentially a B-type fracture instead of a C-type fracture. Here's another example of how you can make this significantly easier for yourself. And again, this requires both experience, understanding the fracture pattern. And if you're considering this, I would tell you should, and we always fuss the residents for getting a CT scan prior to X-Fix, but if there's a chance that I'm going to fix it or part of it, I want that CT scan so that I can understand the fracture as best as I possibly can. All right, and so this patient came, they were, in this position with, medial soft tissue tension for like 12 hours, and the skin is not open, but it's significantly damaged and it's threatened. And there's not going to be any kind of anterior approach happening anytime in the next couple of weeks, but the posterolateral skin is pristine. Okay, and so this is what we chose to do here. The relatively simple fibular fracture pattern, understand the posterior plafond and make the posterior plafond anatomic. Okay, looking at this, and I don't have this pre-op CT scans in this image, but simple fracture pattern there. I don't include, pass my fixation into any portion of the anterior part of the fracture, but I get really good alignment of the talus through a single posterolateral incision, and I can wait for a really long time if I need to fix this anterior plafond because it's really almost already reduced. And this is significantly more stable than it would be in just an external fixer. Okay, so this is what that post-op CT looks like, and you can see all of my fixation is out of the anterior portion of the plafond. but the joint is really quite nicely lined up. There's really not that much else to add. And this makes stage 2 so much easier, especially if you're going to have to wait 3 or 4 weeks. And here's another example. You know, this is what sometimes these medial open traumatic wounds, common, you know, fracture pattern, open fracture pattern failure. You know, the tenuous medial soft tissue is a valgus failure and a transverse tension failure of the medial skin. And they look like this, and the patient smokes, and you really don't want to have to do anything on this, the medial side or even the anterior portion of this ankle. And so sometimes the best access you have is at the first stage. So this is a case of mine. There's a segmental medial column injury here. He's got an extruded Chaput fragment, relatively simple fibular fracture. And so through that large open transverse wound, we're able to restore the medial column anatomically here, leaving essentially the Chaput fragment. There's a displaced posterior lateral fragment here, and it's relatively simple fibular fracture for stage 2, which in this case couldn't be done until, you know, probably almost 3 weeks later. But in the frame, with this mini fragment fixation, you're going to be better set up. And so I think, you know, when you think about it, the only times to do it, you're sure that you're going to be the one to do the definitive fixation. That's probably the most important thing. Number 2 is if you have a portion of the fracture that is going to be inaccessible via another approach, and you can see it through the open fracture wound, then you should think about it. And you should use mini fragment implants or independent screws to help minimize the soft tissue prominence of those implants under the open fracture wound. So approach selection is really important, and it is often dictated by the soft tissue. Like I mentioned, you know, at least at our place, the medial tension failure is probably the most common open fracture pattern. And so that almost precludes the anteromedial approach from the jump. And sometimes, you know, there are other approaches that are challenging. And so it's really important to understand both the soft tissue and the fracture. In general, JMO showed here's just a brief, because we're running out of time, I'm gonna go skip through this portion because you guys can read a textbook about approaches. You know, so I think here is that paper that JMO was mentioning, and understanding the fracture fragments and how you can see what you need to see. From the posterior approaches, posterior medial and posterior lateral, you really will never have direct articular visualization. You're relying on cortical reads to allow you to place that portion of the joint in space, but you will never see it directly unless you have another open approach, okay? And so when we're understanding the articular injury is really important. And as a general rule, if you can see my my mouse here, right? When I'm deciding which anterior approach I'm going to use, I will look at where the fracture line of the Chaput fracture fragment exits in relation to the tibialis anterior tendon. Okay, and because that is going to make it determine where I will be able to access the central and posterior portions of the plafond from the front of the ankle joint. And that's sort of the ideal exposure in my mind. Now, sometimes the soft tissue will not allow you the ideal fracture exposure via that surgical approach because of an open fracture wound, because of a significantly, you know, whatever the reason may be. The open fracture would be the most common. But when we think about the articular injury, you have to be able to see at least a portion of it in almost all circumstances. There are a few, you know, the posterior only plafond fracture, that may be a time where I will accept that my cortical reduction gives me an articular reduction, and I will not be able to directly visualize it via an arthrotomy. But in general, I want to see the articular surface. Okay, so I have to decide how I'm going to get there, and then what I'm going to do to reconstruct the joint, and then how I'm going to hook the joint up to the shaft. Okay, so when you think about the joint, you know, we know, going back to your basic open fracture course, right? Articular surface needs an anatomic reduction. Usually that's done via direct visualization and requires compressive fixation to allow for primary bone healing, right? So you thought that you were past the basic course, and I'll tell you, if you carry it with you everywhere you go, you will not be sad. So in general, here again, the articular surface, right? So this sort of flow chart is something I'll try to go through in my mind for every single case when I think not only about Pilon fractures, but all fractures, particularly periarticular fractures, right? So for the articular surface, I want absolute stability. I need an approach that may not be extensile to the diaphysis, but I need an extensile approach in order to allow me to see the joint. I want a direct reduction, and I want compressive fixation. I don't necessarily need locking fixation. You know, there are times and places to use locking fixation, but in terms of the primary goal of compressing the articular surface, that's done via lag screws. So how do you sequence this, right? So that's you know, some of this is experience and some of this is learning from other people, and I learned from really good teachers. So I think that in general, it's nice to reduce to and build from something that is reliably reduced, okay? And so if you're gonna have an anterior only approach, then you have to build from the back towards yourself, okay? And so that can be accomplished a couple of different ways. Sometimes you get an indirect reduction of the posterior malleolar segment via just traction with the X-fix or fibular fixation or combination thereof. Other times you can directly reduce the posterior malleolar segment or the Volkmann segment through your anterior exposure, okay? And you can see both metaphyseal reads and the cortical reads through the open anterior exposure. And then there are other times where, like in that previous slide I showed, where you can directly reduce the posterior Volkmann segment to the shaft, okay? And so that's really important. And one of the things you can build back to. Another segment of bone that at times you can build back to is the medial malleolar segment. Okay, if you have the medial malleolar segment can be reduced anatomically to the shaft, then you can build everything sort of posterior to anterior and posterior medial back towards yourself posterior, or excuse me, anterolaterally. Okay. And so this is just sort of the standard, maybe you call it traditional pattern with the sort of the upside down Mercedes-Benz sign here. And in this case, the tibial tendon is here, and the anteromedial approach takes me here. So that's where I want to be in this case, right? So you can externally rotate the Chaput segment. I can see the central impaction, reduce it, assess the position of the posterolateral fragment, address any kind of impaction on this leading edge right here. And then I can reduce the medial malleolar segment and the Chaput segment to one another, and I can secure the joint to the shaft, right? So another thing to be mindful of is oftentimes, you know, this is almost like a non-contiguous fracture of the shaft and the joint. And I think that it's quite nice, but you have to be really sure that the positioning of this posterolateral segment is anatomic in order to build back to it. So here there's leading edge impaction, you have to disimpact. Okay, you end up with a joint surface that looks like that after some work, holding the shaft reduced with clamps and then reducing the articular surface. So next, moving to the metadiaphyseal pattern, right? So again, back to basic, your AO basic course, right? A simple fracture pattern lends itself to an anatomic reduction via direct visualization, okay, and compressive fixation, whereas a comminuted metadiaphysis better lends itself to bridging fixation, and then you want to try to think about indirect reduction techniques for those fracture patterns, okay? And so here, you know, the metadiaphysis simple fracture pattern, oftentimes I'm willing to use an extensile approach because I want to make that fracture anatomic, and then I'm going to compress it with lag screws. Okay, so this in this sequence, you know, maybe a C to a B type situation where the metadiaphysis is simple, and I'm going to reduce to something that is intact after I've reduced one of the columns. So if the fracture pattern is more complex, then I'm thinking about a relative stability construct, and I'm going to bridge the comminuted metadiaphysis. And I don't necessarily need an extensile approach to do bridging fixation. Okay, so you have to think about all of these things ahead of time. And there are lots of different options to allow for bridging fixation. I can use a non-locking plate, I can use a locking plate, I can use a nail, I can use a ringed fixator, but I don't have to see every single metadiaphyseal fragment in order to accomplish that goal. So in this situation, when the metastasis is and the metadiaphysis is really complex, then I find in these situations, reducing the joint and then putting the joint in space where it belongs in relation to the shaft is a more effective strategy. And again, you have to build back to something that is an appropriately aligned and compress those articular fracture fragments together. And then you can bridge the shaft, the comminution. All right, so we're sort of running out of time, but I'm going to try to run through a couple cases here. So just in the Q&A, tell me what you think about. Now, we're not going to talk about staging or not staging. This patient will assume they got stage 1. Okay, here's your fracture pattern. Here's your CT scan. Okay, what approach do you want to use and how are you going to fix this fracture? All right, so what we chose an extensile approach because this is a simple fracture pattern in the metadiaphysis, right? We lagged the shaft together and then address the Chaput fracture through direct exposure there as well. Long non-locking plate because we had good medial column support via an intact cortex or a reconstructed cortex. And this is what that looked like, and this is how that patient did. I'll go through one more case, then I'm gonna probably have to quit because we're almost out of time. So think about this case right here. This goes back to some of the points we talked about earlier. This is a significantly short talus. If you can't understand, it's important to look at the talofibular relationships when you're unsure of the placement of the talus. And this is, this fracture is like 2 or 3 centimeters short. The Chaput segment is extruded and there's diaphyseal extension. Okay, so we're going to stage this. This is the initial CT scan. Okay, in this case, again, I made a small posterior medial approach to reduce the diaphyseal component to set myself up for an easier job the second go around. And I did that because I had the CT scan before surgery. So don't always yell at your residents. Sometimes it's useful to have that CT scan beforehand, right? So here's stage 1. Looking at this, okay, so there's a displaced and almost dislocated posterior malleolar segment. Okay, what approaches do you think we use for this? So we have a posterior medial incision, relatively small. Here I did an anterolateral and a posterolateral incision, right? Keeping the fixation out of the posterolateral segment, and then a direct exposure to that dislocated posterior malleolar segment to reduce that. And here's the post-op x-ray. And here he is standing, and here's his ankle. And pretty good motion, not the best motion. And so I think the take-home points for reduction strategy is you need to be able to see, okay, the joint. You need to understand the fracture. You want to be able to visualize the articular surface and effectively address areas of impaction, and that requires access. And that goes back to surgical approach selection. And then when you think about reduction strategies, after you've made sure that you can see, you need to try to build back to something that is reliably reduced, okay? If there is something that can be reliably reduced to the shaft, then I would start there. If the metadiaphysis is significantly comminuted, then in that situation, I try to put the articular surface together and then use indirect means, whether that's fibular fixation or percutaneous plate application, adjustment of the external fixator to allow for bridging fixation of the comminuted metadiaphysis so that I can then hook the shaft up to the joint. And so with that, I will give it back to JMO and we can kind of talk about a few things and wrap up.
Thank you all for your amazing wisdom and sharing all of your knowledge. It is 9:04 now. And I want to respect everyone's time. If there are a few questions that we can help address, and those of you who want to stay on for a minute or two, we're happy to do that. There's one question here about, are you prepping and draping for anterolateral, then posterolateral incisions? And so I'm assuming this means if you're going to be using both some kind of anterior approach as well as a posterolateral, how are you positioning and draping, and how are you doing that?
So a standard posterolateral incision for just fibular fracture fixation is all supine for me. But if I'm addressing the posterior plafond, then it is, it's a bit of a drag, but I'm repositioning from prone to supine.
Yeah, same here. I like to do most of my posterior malleolus fixation prone just because stuff tends to fall down and it's easier the retraction and visualization is much more straightforward. The only time I depart from that is when I feel like I need to work through both windows at the same time. And if one reduction is dependent upon the other, or if I know I want to be able to adjust in the really, really complicated ones, where you just don't have a clear read and you're not sure if you're really got that posterior malleolus down. That's pretty rare. In those situations, I'll have the patient positioned almost lateral, and so you can roll the hip one way or the other. And if I don't have to reposition the patient, then I'm not reprepping and draping. Otherwise, yes, I am.
Yeah, some people call that a sloppy lateral position. That doesn't mean they're almost lateral. That actually means they are lateral, but you make the beanbag a little loose so that you can roll them forward a little bit and be semi-prone, or you can roll them back and be semi-supine. So that's sort of that sloppy position that allows you to do both at the same time. One of the great things about these complex fractures, besides being fun to fix, of course, is that you almost always have time to prepare. And so make a great plan, even if you feel like I've only grasped a quarter of the things that we talked about today. You can think about all those things, talk to your mentors, talk to your friends and colleagues, and make the best plan possible when you walk in, because even when you do that, these are super challenging. Okay, we'll do this last question. We'll do a quick wrap up and then we'll call it a night. What about fixation of Pilon fractures and uncontrolled diabetes? So here's perhaps a pitfall. Anything special that you do for a diabetic patient?
I wait a lot longer. I mean, if it's open, you have to do something. But this is one of those things where, first do no harm. And if you start making big incisions in these patients, even if you can get the joint anatomic, but you leave them with the bad infection, that's a disaster. So for uncontrolled diabetic patients, I would externally fix the patient and then get them under control. And so if sometimes that means they're on an insulin drip at the beginning for the really bad ones, most of the time they stay in the hospital for those first couple of weeks. And by that time, they're kind of captured. And as long as their blood sugars can be under 200 consistently during that perioperative period, then their outcomes are better. And so the number is to try to get it under 200 as much as you can. You want to be able to reconstruct their plafond, but you need to get their blood sugars better. And for people who are totally uncontrolled, and the risk of their infection is so high, like they're regularly in the 300s, can't get controlled, maybe have diabetes, peripheral vascular disease or dialysis patients. Those are the ones where we may consider ring fixators or definitive fixation with an external fixator. There was a question about that earlier. For people for whom the soft tissue compromise is going to be way too risky, that you risk amputation if it goes wrong. So that's rare that they're that bad, but because those patients aren't usually getting these injuries. But that would be a consideration.
Dr. Spiller?
Yeah, I mean, the only thing I would add is, it depends a little bit on the age of the patient. In lower demand patients, if you're 75 and you have uncontrolled diabetes and you weigh 300 pounds, then I would strongly consider something like a hind foot nail, because those patients typically don't tolerate ringed fixtures very well. That's fortunately fairly uncommon, but if they are low functional demand, that is a safer operation, I think, in some settings. It is also, ring fixators require a lot of some patients, both mentally and physically, and their social situations can be really challenging to take care of a ring fixator. And so I'm a little bit leery of that at times if the social situation is not stable. So if they have a good social situation and just really poorly controlled diabetes, then that's a reasonable option for me and my patients. I think patients who are going to walk on it right away, no matter what, because they're going to be discharged to a halfway house, and then they're going to be back homeless again. Something that they can walk on more safely early is something I will consider. So I think it's important to see the whole patient.
All right. Thank you for such great nuances. These discussions can go on for a while because we're all excited about this, and I see there's still over 100 with us, but we're at 9:10. So I'm just going to give a brief final slide because I think it is important, even if we don't go over the details, to at least reflect on what we've just heard so that we could reinforce it. And this is essentially the same slide as you saw at the beginning, but it's now asking you, did you learn to decide when and how to stage the surgical treatment of Pilon fractures? And as you answer that for yourself, go over in your mind, especially as soon as we're done with this webinar, if you have 10, 15 minutes to go over this, think about it, write things down, because if you reflect on it now and test yourself, you're going to remember this for much longer. Can you discuss the risks and benefits of available approaches for Pilon fractures? Try to remember as much as you can from the plethora of information you got today. And can you present a systematic approach to fixation and when to deviate? And have you learned some of the pitfalls and complications and avoidance tactics for these complex injuries? And with that, I would like to thank all of our panelists for educating us and having a great discussion around these complex injuries. And I would like to thank all of the participants for joining us, for giving your time today. Please keep thinking, please keep discussing and doing and getting better. And we'll see you at the next webinar. Have a good night, everyone.